Hello all, welcome to a new video. Today we'll be discussing about localization of stroke. So as far as stroke localization is concerned, the main questions comes from the brainstem strokes. So today we'll be discussing mainly about that. So when you localize a stroke, it can be cortical lesions, it can be subcortical lesion, it can be brainstem, or you even have spinal cord lesions. Today we are mainly concerned about the brainstem stroke. So one peculiarity of brainstem stroke, it is crossed hemiplegia. So there is something called crossed hemiplegia. So what is crossed hemiplegia means? That is hemiplegia on one side and the cranial nerve lesions on the opposite side, or ipsilateral cranial nerve lesion with contralateral hemiplegia is what we call crossed hemiplegia, and that is seen classically in brainstem stroke. That is what one indicator that is indicating us that the stroke is localized to the brainstem. Brainstem is consisting of the midbrain, pons, and medulla. So now we have to understand where in the brainstem. Is it the midbrain, pons, or medulla, or is it on the medial side or on the lateral side? Based on the involvement of cranial nerves and the constellation of the symptoms and the presentation of the patient. Okay, so once we localize, we are localizing it to which side, like left or right, which part of the brainstem, midbrain, pons, or medulla, which part of that midbrain, whether it's medial or lateral. Okay, and then again which blood arteries supplying that area. That we just need to know the blood supply of that area so that we understand which vessel will be affected. So that is about the brainstem stroke. Before going into that, I'll just revise the three main pathways for you so that you have an hold of an understanding of what happens in each pathway and which side lesion, which side of the body will get affected. Okay, so you need to know the sensations being carried by that pathway, where in that the spinal column or in the brainstem or in the brain is it crossing to the opposite side. So the crossing happens either at the spinal level or at the brainstem level, and um, what happens, what are the manifestations of the involvement of that particular tract. So mainly we have three pathways. One is the descending tract, which is our motor tract, which we'll discuss now. After we discuss the sensory pathways, which are mainly two dorsal column tract and the lateral spinothalamic tract. So dorsal column tract is carrying our touch, like fine touch. It is carrying pressure, so touch. It is carrying pressure sensations. It is carrying vibration sensations, and it is carrying 2-point discrimination, proprioception. Okay, so these are the sensations being carried by the dorsal column tract. Okay, and proprioception as well. Okay, like a joint sensation. So if our joint is in flexed position, we need to know, the brain should know that it's in the flexed position. So that sensation is carried again by the dorsal column pathway. So dorsal column pathway reaches the spinal cord through the dorsal the dorsal root ganglion, and then it reaches the dorsal horn of the spinal cord. The first order neuron is the dorsal root ganglion, and then it reaches this dorsal horn of the spinal cord. Dorsal horn is mainly concerned with the sensory pathways, and ventral horn is concerned with the motor pathways. And then it ascends up until the medulla. There is no crossing until the medulla. So it ascends up. So the leg fibers are more medial, and as you ascend up, the fibers are then added laterally. So the leg fibers are most medial, and then you have that is sacral, lumbar, thoracic, and cervical is most lateral. That is as far as the spinal cord level is concerned. Spinal cord transection, if you take, that will be the scenario. So once you reach the medulla, that fibers, the running fibers are called fasciculus gracilis, which are more medial, and fasciculus cuneatus, which is lateral. Gracilis is concerned with the lower limb fibers, and the cuneatus is the upper limb and cervical fibers. And that is reaching the medulla. In medulla, there is nucleus gracilis and nucleus cuneatus. Nucleus is nothing but a group of cell body. The neuron has cell body and axon. Axons are carrying the fibers, the white matter, that is the fasciculus, and nucleus is just the cell body, the group of cell body. So that is called nucleus gracilis and nucleus cuneatus. So fasciculus gracilis is ending at nucleus gracilis, the same name. That is in the medulla. Now in the medulla, it crosses over to the opposite side. In the medulla, it crosses over to the opposite side and it continues as the medial lemniscus. So our dorsal column pathway is called dorsal column medial lemniscal tract. The dorsal column medial lemniscal pathway, which is concerned with our these sensations, touch, pressure, 2-point discrimination, vibration, proprioception. It is not crossing at the spinal level, it is crossing at the medulla only. And then it ascends through the midbrain, through the pons and midbrain, and from the midbrain it goes to the thalamus, because thalamus is the sensory relay center. Whichever sensation from whatever part of the body, whichever tract is carrying, always reaches the thalamus before it is given to the sensory cortex. Okay, sensory cortex. So that is the thalamus, that is the sensory relay center. So we have to know what are the sensations being carried by dorsal column pathway: touch, vibration, proprioception, 2-point discrimination, and pressure. And where is it crossing? It is crossing at the medulla only. So in the brainstem lesion, and it is on the medial side of the medulla, pons and midbrain, and that is called medial lemniscus. And the medial lemniscus is on the medial side, and then it is going into the thalamus and sensory cortex. So these are the sensations, and this is the level of crossing. That is the dorsal column pathway. Now the spinothalamic tract is concerned with pain and temperature. And where is it crossing? So it is called the lateral spinothalamic tract. In the name itself, it is on the lateral side of the spinal cord. So we have talked that the dorsal, this is the ventral root and this is the dorsal root, right? In the spinal cord section, the dorsal root is concerned with the sensory pathway. So through the dorsal root, it reaches the dorsal horn, wherein you have a specific nucleus for the pain and temperature. We're not concerned about the names because there were no questions regarding that. So this nerve, the nucleus in the dorsal horn, will give fiber to the opposite side. Okay, so at the spinal level itself, not the same spinal level, it's 1 or 2 spinal levels above. Okay, it crosses at the 1 or 2 spinal levels above that. So you're not concerned about that. You mean that it is crossing at the spinal level itself. So even the spinal lesions, pain and temperature will be lost on the opposite side, because contralateral pain and temperature is being carried by this side. Suppose it's a right-sided spinal cord, which is right half of the spinal cord is affected, means left pain and temperature will be lost because it is crossing at the spinal level itself. Then it reaches the medulla on the lateral side itself, pons, then midbrain. Finally, it goes to the thalamus because thalamus is the sensory relay center, and finally it goes to the sensory cortex. So this is about the dorsal column tract, and this is about lateral spinothalamic tract. Remember, lateral spinothalamic is concerned with pain and temperature. So you need to know the sensations being carried by this tract, where is it crossing, and what will be the manifestation. Now we'll just discuss about the motor tract also, because motor tract also, when a patient is coming with hemiplegia, that means the motor tract is affected. So motor tract is coming from the motor cortex, not just from the motor cortex. It is from, some fibers are coming from the accessory motor cortex and also from sensory cortex. Okay, you should not be concerned about the percentage of fibers and all, but remember that it's not just solely from the motor cortex. It's also the contribution is from sensory cortex as well. And then it comes down like the corona radiata. Okay, that is the radiating fibers from the cortex, that is called corona radiata. It is condensing at the internal capsule. That's why we have dense hemiplegia when there is internal capsular lesion. Then it is fanning out again, going to the brainstem. Brainstem again on the medial side. Motor pathway will be on the medial side of the brainstem. midbrain, pons, and medulla. Once it reaches the medulla, especially on the lower part of medulla, it crosses over to the opposite side. That is called pyramidal decussation. So it is at the pyramid or the medulla, whereas it is crossing to the opposite side. 80% fibers cross over, that is called lateral corticospinal tract. 20% runs down as the anterior corticospinal tract, but ultimately that is also crossing over. You're not much concerned about that. So it is crossing over at the medullary level. Then it is going down to the anterior horn, because anterior horn is the one concerned with motor pathway. We told dorsal horn concerned with sensory pathway, anterior horn concerned with motor pathways. So there is something called anterior horn cell, which is the lower motor neuron, and from anterior horn cell to the nerve which is carrying the sensation to the concerned skeletal muscle, that is constituting the lower motor neuron. And everything above that, anything above the anterior horn cell, becomes the upper motor neuron. So this is our motor pathway. Again, it is crossing at the medulla. So pain and temperature, lateral spinothalamic tract, crosses at the spinal level. The dorsal column tract, touch, pressure, 2-point discrimination, vibration, proprioception, crossing at the medullary level. That is running as the medial lemniscus. Pyramidal tract, motor pathway, crossing at the medulla, pyramidal decussation, and it is running down, okay, as the pyramidal tract, lateral corticospinal tract or pyramidal tract. Okay, so this is again an image which I've added just to know what is happening, where is it crossing, what are the sensations being carried. So now we'll come to the brainstem stroke proper and understand what are the keys to localize the lesions. So we have told that it's a closed hemiplegia. So there is a cranial nerve nuclear involvement, and any cranial nerve involvement, which is the cranial nerve nucleus, that is like it is equivalent to the anterior horn cell of the motor tract. The anterior horn cell and beyond is our element. So cranial nerve nucleus and beyond, that is that corresponding cranial nerve, becomes our element. So that will be ipsilateral. Okay, so ipsilateral cranial nerve lesion with contralateral hemiplegia, which is called closed hemiplegia, is an indication that it is a brainstem stroke. Now, where in the brainstem? Because we have midbrain, pons, and medulla, we have to localize to one part. Most of the questions have come from lateral pontine and lateral medullary, but we'll cover all of that so that we know where in the brainstem exactly is it happening. So in order to understand where in the brainstem, there is something called rule of 4, which means our 4 lower cranial nerves, 9, 10, 11, 12 comes from medulla. The middle 4 cranial nerves, that is 5, 6, 7, 8 comes from pons, that is lower part of brainstem is medulla, so lower 4 cranial nerves. Middle part of brainstem is pons, and that is middle 4 cranial nerves. And the upper 2, because in brainstem lesions, we are not concerned about the first and second. First is olfactory nerve and second is the optic nerve. They're not reaching the brainstem, or as far as we are concerned, we are not concerned about both of that. Olfactory nerve is running through the cribriform plate and is reaching the olfactory lobe. Optic nerve is reaching the occipital lobe, right? So we are concerned about 3 to 12. So 3, 4 in the midbrain, 5, 6, 7, 8 in the pons, and rest 4, 9, 10, 11, 12 in the medulla. That is called rule of 4. There is also one rule of 4, that is 4 cranial nerve nuclei are in the medial part. That is 3, 4, 6, and 12. Okay, 3, 4, and then 2 multiples of 3. You can remember like that, 3, 4, and 2 multiples of 3, which are 6 and 12. So 3, 4, 6, 12 are on the medial side, all others are on the lateral side. Okay, so this is so if there is a third nerve involvement, it is indicating midbrain. If it is fourth nerve, again midbrain. Sixth nerve, pons. 12th nerve, medulla. So again, if there is 3, 4, 6, 12, that also indicates it's a medial lesion. So medial cranial nerve nucleus, which are 3, 4, 6, 12 involvement, indicates that it's a medial lesion. because we just don't want to localize it to whether midbrain, pons, or medulla. We have to know whether medial midbrain or lateral midbrain. So medial sided lesions, again, there is 4M. 4M. These are rule of 4. One is the 4 cranial nerves arising from medulla, 4 cranial nerves from pons, 2 cranial nerves from midbrain. Then there are 4 cranial nerve nucleus which are running on the medial side of the corresponding brainstem part. That is 3, 4 in the medial midbrain, 6 in the pons, and 12 in the medulla. And there are 4M, which is indicating that it's a medial lesion, medial corresponding lesion. We're not saying medial pons or medulla. We are just saying it's a medial lesion, like 4 medial cranial nerve nuclei, which is 3, 4, 6, 12. If it's motor tract involvement, if there is hemiplegia or hemiparesis, there is motor tract involvement. That again indicates that it's a medial lesion. Medial lemniscus, which is our dorsal column tract. So there is the touch pressure from the right side is lost. That means the left medial side will be affected. That is medial lemniscus. Medial longitudinal fasciculus, it is concerned with the conjugate gaze, and there is something called internuclear ophthalmoplegia, which is a manifestation of MLF lesion. That means there is an ipsilateral adduction palsy with a contralateral nystagmus. That is the classical description of internuclear ophthalmoplegia. So if any of this happens, there is that indicates that it's a medial lesion. So medial 4 cranial nerves, which is 3, 4, 6, 12, motor tract involvement, medial lemniscal involvement, and medial longitudinal fasciculus. Then what are the lateral lesions? What are the pointers to lateral lesions? That is 4S. S for side or S for lateral. Side means lateral. S for spinothalamic tract, which is concerned with our pain and temperature. Sympathetic tract, which is the presentation is Horner's syndrome. There is ptosis and hydrosis, meiosis. Okay, spinocerebellar tract. So the patient can present with ataxia. Spinal nucleus of trigeminal nerve, which is concerned with the sensations from that same side of the face. Ipsilateral facial sensations. All the sensations will be carried by the trigeminal nerve. So these are the lateral lesions. So we are just talking about the lateral and medial. We are not talking about the midbrain, pons, medulla proper. We are talking about lateral and medial. Medial means the 4 medial cranial nerves, 3, 4, 6, 12. Motor pathway, medial longitudinal fasciculus, and medial lemniscus. 4S is for the side or lateral. Spinothalamic tract, spinocerebellar tract, which the patient can present with ataxia. Then sympathetic tract, patient presenting with Horner's, and spinal nucleus of trigeminal. Trigeminal has different nucleus. That is why we talk about spinal nucleus, which is concerned with the facial sensations from the same side of the face. Okay, that was the medial versus lateral, and where the cranial nerves are situated. Now, what will be the manifestations? We have to pick. They won't say they come with third nerve palsy. The question will describe the symptoms of the patient. So, what are the symptoms or presentation of third nerve nucleus lesion or third nerve palsy? There is ptosis. The pupils will be dilated. Eye is down and out. Why is this happening? Because the oculomotor nerve is supplying the constrictor pupillae. If the constrictor pupillae is affected, the pupils will be dilated. The eye is down and out because oculomotor nerve is the one supplying all the extra ocular muscles except LR6-SO4. LR6-SO4 means lateral rectus is supplied by the 6th cranial nerve, which is the abducens nerve, and the superior oblique is supplied by the 4th cranial nerve, which is the trochlear nerve. Except this, all the extraocular muscles are supplied by the oculomotor nerve. So once oculomotor nerve is affected, all the extraocular muscles except for the lateral rectus and superior oblique will be affected. So lateral rectus is bringing the eyes to the abducted position, and the superior oblique is bringing it down. So it is down and out. And there is also ptosis because for eye opening you need 3rd nerve, for eye closure you need 7th nerve. 4th cranial nerve is concerned with lateral gaze palsy because it is supplying the superior oblique. Fifth cranial nerve, facial sensations on the same side will be absent because that is one that is carrying all the sensations, pain, temperature, pressure, everything from the face is being carried by the fifth cranial nerve. Sixth cranial nerve, they'll present with lateral gaze palsy because lateral rectus is supplied by the sixth cranial nerve. Seventh, that is facial palsy, ipsilateral element facial palsy, which is Bell's palsy. There is a problem with the eye closure, wrinkling of forehead will be lost, nasolabial fold will be lost, and the angle of mouth will be deviated to the opposite side. Okay, in seventh cranial nerve, angle of deviation of mouth is to the opposite side, but in 12th nerve, the tongue deviation is to the same side. We'll talk about it in a bit. Eighth cranial nerve is concerned with hearing loss because that is the one carrying the hearing sensation. 9, 10, 11 is concerned with dysphagia and the gag reflex can be absent. Also in 10th cranial nerve, there can be hoarseness of voice because recurrent laryngeal nerve is a branch of vagus nerve or 10th cranial nerve. 12th cranial nerve, the tongue on protruding the tongue will be deviated to the same side of lesion. So we'll talk about what we have talked. There is something called rule of 17 or 10, or you can remember like 10 plus 7. 10 plus 7 is what? 17. 10 plus 7 is 17. Also 12 plus 5 is 17. So 12th cranial nerve, if there is a lesion, the tongue will be deviated to the same side. Also for fifth nerve, which is our the trigeminal nerve, there will be deviation to the same side. Deviation of what? Deviation of jaw to the same side. Then 10 plus 7 is also 17. So 10th cranial nerve, vagus nerve. Okay, there is deviation of uvula to the opposite side. 7th cranial nerve, facial nerve, there is deviation of angle of mouth to the opposite side. So these two are 17, that is to the opposite side. 12 plus 5 is also 17, that is to the same side. That is how we remember it. Okay, that is regarding the cranial nerve palsies and what will be the manifestation. Okay, so we have now localized the lesion. So suppose there is a presentation where the question describes like a 48-year-old male presenting with ptosis. The eye is pupil is dilated, the eye is down and out, and on the left side, and there is right-sided weakness. So the patient is coming with right-sided hemiplegia with left-sided third nerve palsy. Ptosis, pupil dilated, eye down and out means third nerve palsy. So ipsilateral cranial nerve with contralateral hemiplegia, that is closed hemiplegia, that is pointing towards brainstem. Where in the brainstem? Third nerve means midbrain. Midbrain is where the third nerve nucleus is situated. So midbrain. Where in the midbrain? Medial part of midbrain, because third nerve is medial, motor pathway is also medial. So medial midbrain syndrome, which is otherwise called Weber syndrome. So contralateral hemiplegia with ipsilateral third nerve palsy is otherwise called Weber syndrome. So now we'll just talk about the blood supply also. So we know the two vertebral artery is vertebral artery, which is a branch of subclavian arteries coming from both the sides. It is joining in the middle, forming the basilar artery. Basilar artery is running in the pontine, the basilar sulcus, which is concerned with the running of basilar artery. So it is running over the pons. So basilar artery will be supplying the pons, especially in the medial part of pons. There will be pontine branches from basilar artery. And the basilar artery is ending at or bifurcating into two posterior cerebral artery. So in the pons you have basilar, vertebral is coming and joining as the basilar, and basilar is ending as the posterior cerebral. So what is below the pons? It is medulla. What is above the pons? It's midbrain. So midbrain is supplied by posterior cerebral artery. The medial side, lateral side, everything is supplied by posterior cerebral artery. Medial part of pons is supplied by pontine branches from basilar artery or basilar artery. You can just say basilar artery. And there is another branch coming from the basilar artery, which is called ICA, anterior inferior cerebellar artery. That is ICA. That is the lateral pons. Now you have vertebral artery, which is in the medullary region. Okay, And the vertebral artery is giving a branch which is called anterior spinal artery. It's also giving posterior spinal artery, but when we are concerned with medulla, we are concerned with anterior spinal artery, because anterior spinal artery is not only supplying anterior two-thirds of spinal cord, it's also supplying the medial part of medulla. And there is another branch from the vertebral artery which is called pica. So we have an ICA, so we should have a pica. Posterior inferior cerebellar artery, branch of vertebral artery, it's supplying the lateral part of medulla. So there are named syndromes. One we have discussed, Weber syndrome. Then we have a lateral medullary syndrome or Wallenberg syndrome. That is the most commonly asked question, is from Wallenberg syndrome. So how will the presentation be? So there will be spinothalamic tract involvement. So the patient is coming with the pain and temperature lost from the right side of body. The right side pain and temperature is lost. There can be presentation of Horner syndrome, like there is ptosis and hydrosis, meiosis, or they can simply say there is Horner syndrome. Okay, and the facial sensation is also lost. So right-sided pain and temperature from the body and left-sided pain and temperature from the face is lost because it's crossed hemiplegia. Fifth cranial nerve on the left side, and pain and temperature from the lateral spinothalamic tract on the right side, because the lateral spinothalamic tract is crossing at the spinal level itself. Cranial nerve nuclei presentation will be on the ipsilateral side. So if it is left, facial sensation lost means it is left fifth nerve. Left fifth nerve means fifth nerve is on the side or lateral. Which part of the brainstem we can't localize from the just the fifth nerve, because fifth nerve is running all through the midbrain pons and medulla, but the most common lesion is lateral medullary syndrome, and that is concerned with the pica syndrome, that is posterior inferior cerebellar artery. Posterior inferior cerebellar artery syndrome or pica syndrome, or lateral medullary syndrome or Wallenberg syndrome. This is the presentation. Usually there is facial sensation on the face on one side and contralateral hemi anesthesia from the body. Okay, hemianesthesia and pain and temperature will be lost. Okay, those are the named syndrome. There is also another thing which is called CPA syndrome or CP angle tumor, cerebellopontine angle tumor. Mainly the nerves involved will be fifth and eighth, as well as far as brainstem stroke is concerned, we are mainly concerned with this. Midbrain pons and medulla. Medial midbrain is called Weber syndrome. Lateral medullary is called Wallenberg syndrome, and the blood supply is by pica. That is the main frequently asked question. So this is regarding the brainstem stroke. Hope you have understood. We'll discuss another topic in the coming session. Thank you so much.